You have various different subtypes of depression. I've talked about them a little bit earlier, the melancholic type, the atypical type. The thing I didn't mention yet about atypical depression is that they actually respond best to the MAOI inhibitors. Even though we rarely use them ever because of their bad side effect profile and their toxicity, you do need to know, because on the test they may ask you what is the most effective treatment for someone described as having atypical depression, which is the hypersomnia, hyperphagia type of thing. So they're saying what's the most effective, and they'll give you some choices between a tricyclic antidepressant and SSRI antidepressant, and they may throw on there an MAOI. Your answer is going to be an MAOI. Now, that's completely different than a question that would ask, what is your first line treatment for this patient with atypical depression? Because our first line treatment is still an SSRI. It's an SSRI for all of the different subtypes of depression. Not because they work better, but because their side effect profile is much better, much safer. Patients tolerate it a lot better. And they work pretty well. But they could ask you a trick question, so just keep that in mind. Alright, you can also have psychotic symptoms in major depressive episodes, something called double depression. We'll talk about that a little bit when we get to dysthymic disorder, but it's basically someone who has dysthymic disorder and then they end up getting major depressive episodes on top of their dysthymic disorder. And then seasonal affective disorder. It just varies with the seasons. Treatment is with SSRIs and light therapy. Alright, so the next thing we'll talk about is postpartum blues versus postpartum depression. Postpartum blues. This is a real short period of mood lability, decreased concentration, poor sleep. It starts about 2 to 4 days postpartum. It lasts maybe 2 days, 3 days. Sometimes it can last a little more than a week. Does not require medication, but watch it carefully because these patients who experience postpartum blues have a higher likelihood of having postpartum depression later on, which is much more serious. So with postpartum depression, it is a subtype of major depressive disorder. It has to occur within 4 weeks postpartum. It's much more serious than the postpartum blues. It lasts 2 to 6 months, but patients can have symptoms for up to a year. It can also present with psychosis, which is kind of rare. So it's way less than 1%. But some severe symptoms they could have are not being interested in the baby, so if they're not caring for the baby, things like that, suicidal ideation or homicidal ideation towards the baby. These are really serious symptoms. You need to treat by making sure first off that the mom and the baby are safe. Give SSRIs, treat with psychotherapy, and in really severe cases you might want to even consider ECT. Okay, the next thing is depression NOS. Depression NOS stands for not otherwise specified. So if we have someone who's depressed and they don't meet criteria for major depressive disorder, dysthymia, adjustment disorder, or they don't really fit in anywhere, we might call them depression NOS. For your test, you don't really need to know this, but just for practice, you should know that it does exist. We have NOS categories for pretty much all the different diagnoses if things don't quite fit perfectly into these specific categories, which happens sometimes. So here's the different types of depression NOS. We have something called minor depressive disorder, recurrent brief depressive disorder, premenstrual dysphoric disorder. This one sometimes comes up for you guys. It's markedly depressed mood, some anxiety, affective lability, decreased interest and it has to be during the last week of the luteal phase of the menstrual cycle. Usually resolves in a few days. It's usually really self-limiting. But when it becomes a big problem, this is when you might want to treat with SSRIs or maybe even benzodiazepines in extremely severe cases. But for the most part, you're going to want to treat with SSRIs. They tend to work pretty well. Fluoxetine, which is Prozac, works well for this. Alright, the next thing is dysthymic disorder. So this is a chronic mild depression. Most of the time they don't have any real discrete episodes. It just is, they're just depressed, and it lasts for at least 2 years. If they're children, it only needs to last for 1 year. And during this period of 2 years, the patient hasn't been without symptoms for more than 2 months at a time. They haven't had a major depressive episode or a manic or a hypomanic episode. If they have, it's something else. You can have dysthymic disorder and major depressive disorder. Those are two separate diagnoses. You can have both of them. That's possible, and in that case it would be called a double depression. But you have to keep in mind that most of the time they're not going to. They're just going to have this dysthymic disorder. It's going to be 2 years, and the majority of the time they're going to be depressed. So they have to have at least 2 of the following: poor concentration, hopelessness, appetite problems, insomnia or hypersomnia, fatigue, lack of energy, and low self-esteem. So it's a little less than a real major depressive disorder. It's like a lighter version of depression. It's a lot more common in women. Onset is around 25 or earlier than 25. Most patients go undiagnosed or untreated for many years because having only a couple of those depressive symptoms make you a lot more able to function, but at the same time, it's going on for a really long time, and after a while, a lot of these patients do end up coming to treatment eventually. There is a pretty decent prognosis when they get the proper treatment. One of the best treatments are cognitive behavioral therapy along with antidepressants. This usually works the best. Dysthymia can occur, like I said, comorbidly with major depressive disorder. When this happens, it's called a double depression. The next thing we're going to talk about is adjustment disorder. This is a stress-related phenomena in which the sufferer experiences significant dysfunction and symptoms, which are relieved when the stressor is removed. So basically, with adjustment disorder, something bad had to have happened to the person. Alright? Something like they lost their job, they got a divorce, they moved across the country, something happened, and then they started having symptoms. So they can have a lot of different types of symptoms: emotional, depressed, anxious. Behavioral symptoms they're more often seen in kids. And the symptoms have to start within 3 months of the stressor. Really important. 3 months of the stressor, these symptoms start. Alright? Also, these symptoms have to be in excess of what would be expected from the stressor, and must cause significant impairment in social or occupational functioning. So, if somebody's going through a divorce or someone just lost their job, it's normal to be upset about it. But it's when these symptoms start to become in excess of what a typical person going through the same thing would be experiencing, and the level of social or occupational functioning. You have to take that into account. Also, the symptoms that they have for adjustment, they can't meet criteria for Axis 1. So they can't meet criteria for major depressive disorder. They can't meet criteria for generalized anxiety disorder. So they usually have less symptoms with adjustment disorder. The other big point is that the stressor can't be the loss of a significant person. If it was, then it would be called bereavement. Okay, so those are adjustment disorder and bereavement are two separate things. Treatment for adjustment disorder, usually you want to try to give some supportive type of therapy, help them with their coping mechanisms, help to intervene and reduce the stressor if at all possible, maximize their social support, get their family involved, get their friends involved. We might use medications every once in a while if their symptoms are really bad. Alright, the next thing is grief and bereavement. Grief is also called bereavement. They're used interchangeably. But it's normal. It's a response to a significant loss. Grief's affected by a lot of different things. Cultural norms, personality styles, how abrupt the loss was, the significance of the lost person or the object, the extent of the preparation for the loss, and the type of death. Suicide is a lot worse for people grieving than if somebody were to die of natural causes. So it often appears as a temporary depressive symptom, so it's normal when someone close to you dies. You're going to be sad. You're going to have problems sleeping. You're not going to be able to eat that much. And you're not really going to be that interested in a lot of things because you just lost somebody. And that's completely normal. However, there is a significant portion of grieving patients that do go on to eventually develop major depression. And you need to be able to distinguish what's normal grief from what is major depressive disorder. So, in normal bereavement, patients can come in, they could have passive suicidal thoughts, which is way different than active suicidal thoughts. So passive suicidal thoughts would be like a longing to want to be with the deceased person, or maybe wishing that they had even died with the deceased. If that's all that's going on, that could be normal. But when you ask for more details about this, they clearly do not have any active suicidal plans. They say they would never ever do something like that, that they just kind of wish that they were with that person, and that's normal. Again, so any active suicidal thoughts or suicide attempts or gestures is never normal in bereavement. If you see that, you have to think that it's probably major depressive disorder. And at that point, you don't even take into account how much time has elapsed. If they get to that point, then it's major depressive disorder. Okay? If they hear a voice or see the face of the deceased person, it could be normal in certain cultures. So certain Hispanic cultures or other cultures, this could be a normal type of process for someone grieving. So take that into consideration. It does not necessarily mean that the patient is psychotic. However, if they're seeing and hearing voices constantly, and it's interfering with their functioning and it's happening all the time, that's something different. They're talking about the person was like in their room and they thought they heard something, or thought they saw something and then it wasn't there. These are really, really brief things that would happen culturally. Okay, also it's really important to pay special attention to patients grieving the loss of a loved one due to suicide, as they have a much higher risk of suicide themselves. So, symptoms of major depression, which is not explained by normal bereavement, these are the things that you need to think, okay, this is major depressive disorder, this is not normal bereavement if you see them. Constant thoughts of being worthless or hopeless, ongoing thoughts of death or suicide, being unable to perform day-to-day activities, intense guilt over things not done, delusions, hallucinations, slowed body responses and reactions, extreme weight loss, so like I'm talking 20, 30 pounds weight loss. If you see symptoms like these dysfunctional type of symptoms, and they're lasting for more than 2 months after the loss, then they should be diagnosed with major depressive disorder, which is also sometimes referred to as complicated bereavement, but it's technically major depressive disorder. Normal bereavement symptoms that don't cause significant dysfunction in the patient's life can last for up to 1 year. So this is where all the trickiness comes in. Because you can be sad for up to a year, but you're going to go back to work, you're going to go back to school. So with normal bereavement, like I was saying, it's normal to be sad for up to a year, but you're going to continue to function if you're going through normal type of bereavement. You're going to be able to perform your day-to-day tasks, and you'll still socialize. You're not going to be withdrawn. You're going to go to work. You're going to get your things done that you need to get done, but you're going to have sad moments, and you're not going to feel completely like your normal self for maybe up to a year, and that's fine. These are the clues. On this slide, these are the clues that are going to tell you this is not normal bereavement. This is probably more like major depressive disorder. And the biggest thing I can emphasize is psychotic symptoms and active suicidal thoughts are never normal. And if you have those, you don't need to wait 2 months to diagnose major depressive disorder. You can diagnose something else right